For this week's case study, I have chosen Adult Respiratory Distress Syndrome, or ARDS. ARDS is a syndrome caused by widespread alveolar, capillary, and epithelial damage as a result of either direct lung injury from things such as pneumonia, aspiration of gastric contents, inhalation injury, pulmonary contusions, things like that, direct injury to the lung tissue, or as a result of indirect lung injury. And, this is going to be things that, it's going to be from the inflammatory process, and the release of cytokines like tumor necrosis factor and interleukin 8 and interleukin 1, and all, the whole cascade that comes with that. And things that cause that are like sepsis and severe trauma with shock, acute pancreatitis, uremia, basically anything that's going to cause this big systemic inflammatory process. Approximately 85% of patients develop ARDS within 72 hours of the initiating insult. And by initiating insult, of course, I mean all of those things that I was just naming off. Mortality rates are decreasing with improvements in treatment from 60% down to 40%, although 40% is still high. For those who survive the acute phase, either you will have diffuse interstitial fibrosis, which comes from the remodeling and healing of the inflammation. So you'll have this diffuse sort of fibrosis, pulmonary fibrosis, which leads to chronic compromised lung function. Or there are people who kind of get lucky and avoid that fibrotic healing, and they can return to with normal lung function within like 6 to 12 months.
As a neonatal nurse, infant respiratory distress syndrome is something that I am familiar with. However, the manifestation of adult RDS is much different. I found an article by Zazi entitled Clinical and Pathological Comparison of Adult Respiratory Distress Syndrome and Infant Respiratory Distress Syndrome, which explains the differences between the two. In adults, the most common cause of RDS is infection, shock, and injury, while infant RDS is most commonly the cause of meconium aspiration while in utero or during vaginal delivery. Pathologically speaking, adult RDS activates the complement cascade, starting the inflammatory process, whereas in infants and neonates there is an insufficient amount of surfactant production and damage to the epithelial cells lining the lungs.
Okay, so taking a quick look at the case study, I'm just going to read through it briefly. We have a 30-year-old white woman presenting to the emergency department with fever, chills, and shortness of breath for 24 hours. She was well until 4 days earlier when she noticed pain on urination, followed shortly thereafter by pain in her left flank. She had diabetes, treated with insulin. On arrival, the patient's blood pressure was 70 over 40 millimeters mercury, pulse was 120 beats per minute, respiratory rate was 24, and temperature was 39 degrees Celsius. On examination, wet rales were present in both lungs, and there was tenderness in the left flank. Chest X-ray revealed bilateral diffuse pulmonary infiltrates. Lab results were as follows: white blood count 14,000, 82% neutrophils, 7% bands, hematocrit 26% with fragmented red blood cells on peripheral smear, platelets 25,000, PT 18, PTT 80, ABGs, pH 7.25, PCO2 36, PO2 28, creatinine 4.8, glucose 600, urine was cloudy with positive protein and neutrophils. The patient was intubated, placed on dopamine, 100% FiO2, and IV antibiotics. She experienced progressive hypotension, an upper GI bleed, and intractable acidosis. Blood cultures grew out gram-negative rods, and she died on the second hospital day. At autopsy, her lungs were heavy, firm, red, and boggy. Okay, so just a brief kind of examination of the case study. The patient on presentation showed evidence of severe sepsis, and you get that from the fever, hypotension, tachycardia, leukocytosis, cloudy urine, positive UA. Of course, eventually later she did end up growing out gram-negative rods in her cultures, which is usually E. coli, which is what you find in urosepsis. Of course, I'm extrapolating that. For looking at ARDS, her chest X-ray shows diffuse infiltrates, Grayles on exam, and profound hypoxia and acidosis, which are kind of hallmarks of ARDS in the presence of sepsis. She also has coagulopathy and acute renal failure, which are kind of they could be a couple of things: multi-system organ failure secondary to septic shock, or she was a diabetic. Maybe her urosepsis was glomerulonephritis even, and that could have progressed to some sort of renal failure, acute tubular necrosis. I mean, there's a lot of things. So on autopsy, the note that her lungs were heavy, firm, red, and boggy, that is indicative of acute phase ARDS, and that appearance of the heavy, firm, red, boggy lungs comes from the alveolar hemorrhage and collection of neutrophils in the capillary bed of the lungs, which is probably what contributed to her. Well, she had a lot of things contributing to her death, but anyway, there. So that's a brief little picking apart of the case study. Okay, the first of my 3 articles that I'm going to discuss for this case study is, it was published in 2013 in the Critical Care Journal, and it's titled Biomarkers of Lung Epithelial Injury and Inflammation Distinguish Severe Sepsis Patients with Acute Respiratory Distress Syndrome. And that was written by a bunch of people. It's Lorraine Ware et al., we'll say. So this was actually a very fascinating study. It was exciting. I was talking about it after finding it. I was talking about it at work with some doctors that I work with because I found it so fascinating. Essentially, the article starts out talking about biomarkers and how we use them in the diagnosis and management of cardiac disorders. So, we have the troponin and the BNP, which is what we use to detect, CHF and MI, and then and it's also what guides treatment. When you're measuring BNPs, that's how you know if they're overloaded and whether you need to diurese or whatever. But we don't really have any good identification for plasma biomarkers for the diagnosis of ARDS, right? I mean, we don't have it for a lot of things, but ARDS has got such a significant showing in critical care and in ICUs, and we lose a lot of patients to it. It would be great if we could identify it early and help manage it. So that's what this study is looking at. We could not only could we identify ARDS early, but we could, once we identify the biomarkers, then maybe we could help design better medications for it. And these kind of applications go on and on. So they looked at a lot of data, and I won't go through all of it because it's extensive, but they kind of did a little research first, and they decided that, unlike the troponin for cardiac, the cardiac muscle release is just this kind of one biomarker, right? Well, when ARDS, you have so many different factors going on that it would have to be a multiple biomarker approach for diagnosis. So they're going to have to look at several things. So it would be kind of like a panel to make a diagnosis of ARDS. So what they did is they did a retrospective nested case control study, and they used information from another study, which it was done in Vanderbilt. It's called the VALID study. It's a validating acute lung injury biomarkers for diagnosis study, VALID study. And what they were doing is they were kind of looking at a lot of the same stuff, biomarkers for acute lung injury. I won't go into all of it because it's irrelevant at this point. But so basically they took that information and then they built from there. So for this study, they took 100 patients with severe sepsis and no evidence of ARDS. And they served as controls. And then they took 100 patients with severe sepsis and ARDS on at least 2 of the first 4 ICU days. Okay, so they had to have sepsis and ARDS on at least the first 2 days. And then they drew this selected panel of biomarkers that they had decided on. And the way that they picked them, again, was from this other study, but they had trauma-associated ARDS biomarkers. So, you've got ARDS that develops from sepsis, and you've got ARDS that develops from trauma, and ARDS that develops from, all kinds of stuff. So there have been studies done on trauma-associated ARDS, and so they used the top-performing biomarkers from that study, which, I can list them all. The receptor for advanced glycation end products, or RAGE, oddly, is what it's called. The procollagen peptide 3, BNP, angiopoietin 2, interleukin 8. That's those. And then they also added some of their own biomarkers that they were just going to test that was looking for lung epithelial injury and inflammation, like surfactant protein D, club cell secretory protein, interleukin 6, biomarkers, and then biomarkers that have been associated with other lung diseases. So matrix, oh my gosh, I'm not going to say this right, metalloproteases, whatever, MMP 1, 3, and 9. So anyway, they created this big panel. And that's what they collected on these 200 people, 100 controls and 100 of the study people. So basically what they discovered in all of this is that they were right. As hypothesized, they used a logistic regression model, and they collected all the biomarkers and found that they were able to determine, although the best performing biomarkers for the diagnosis of ARDS in the presence of sepsis is different than the best performing biomarkers for patients in the presence of trauma. So they are different, although there was a little bit of overlap. So it doesn't really matter which ones were which for this purposes of this conversation. But so they decided there are 5 biomarkers in plasma that provided excellent discrimination for the diagnosis of ARDS in patients with severe sepsis, as assessed by this ROC curve analysis. 3 of the 5 biomarkers were generated by the lung epithelium, which kind of confirms that lung epithelial injury is the critical determinant of, how much alveolar, fluid filling happens, because when you have that damage to the epithelium, that's what my picture is looking at here. You get that damage to the alveolar epithelium, and then it fills up with that protein and fluid, but the fluid shifts, and that's what causes the hypoxia, because you can't have gas exchange when there's a literal fluid barrier in the way. So yeah. So once they determine these 5 biomarkers, they can use them to confirm the diagnosis of ARDS and maybe develop some better treatment protocols. Anyway, very exciting stuff. Very exciting stuff. My next article is also from Critical Care Journal. That was from 2015, and it was written by Carol Bromzik and et al. And it's called Experimental Acute Lung Injury Induces Multi-Organ Epigenetic Modifications in Key Angiogenic Genes Implicated in Sepsis-Associated Endothelial Dysfunction. Okay, so talking a little bit more about this endothelial dysfunction. So we've established how important that endothelial dysfunction is in the evolution and progression of ARDS. So now they're kind of looking at the epigenetic changes in the angiogenic genes, because so in the endothelium, you've got the endothelial growth factor receptor ligand systems. You've got the VGEF and the VGEFR, and then there's other ones, the Tie2 and angiopoietin, all of those. And they regulate that endothelial function. So during sepsis, they've discovered that there is an epigenetic kind of down regulation of these genes that allows for kind of a microvascular leak, which adds to the problem of not just ARDS, which is the whole point of this study, but it's not just ARDS, but but end organ dysfunction in other organs as well. So they did this study, and they investigated a serum albumin leak, changes in gene expression, and associated epigenetic alterations in a murine model of acute lung injury-induced sepsis. And basically what they found is that experimental acute lung injury sepsis induced microvascular leak and downregulation expression of angiogenic genes, and those are the VGEF and the VEGFR. I'm not going to say those right. The greatest response was observed in the lung. So when you have sepsis, you have these epigenetic changes in the endothelium, but these specific 1, 2, 3, 4 of them have the biggest change in the lung. So acute lung injury sepsis reduces levels of transcription, permissive histone, H3 lysine acetylation at the lung, the kidney, and the liver the most, but most significantly in the lung, which might be why you have ARDS and multisystem organ failure, but ARDS especially. The benefit to knowing this kind of information is they can, when you have this awareness of the role that the endothelium plays in the organ responses to sepsis, you can kind of use that information to identify kind of target organs and medications that target, and they can help design new medications that can target these I'm not saying it right, these histone modifications. They said here several drugs that target this pathway are currently in clinical testing for other diseases, but have not been evaluated in sepsis. So mapping epigenetic modifiers tethered to angiogenic loci during sepsis is a promising approach. So I agree. I think it's exciting. And then my last article is, I thought, a little different take. The title of this article is the New England Journal of Medicine, and it is from June 2014, and it is written, where's the name of my book? It's called Rosuvastatin for Sepsis-Associated Acute Respiratory Distress Syndrome. And interesting enough, this I found, I find a lot, research interests me when it's all about things that, that we could be doing or that we should be doing, or new things that we could be doing. But I also I'm interested in research where they tell us what we thought we were supposed to be doing that it turns out we're not supposed to be doing. So that's why I included this in that. Apparently, there have been all of these previous studies out there suggesting that statins improve clinical outcomes in patients with sepsis, specifically in patients with sepsis-associated ARDS. because if we remember from a couple chapters ago, statins are anti-inflammatory, right? They're inhibitor of 3-hydroxy-3-methyl-glutarol coenzyme A. Okay, they're like a COX, one of those reductase. I can't name all the things that it is, but it's an anti-inflammatory. So they had been giving these medications to people who with ARDS who were on the ventilator, because there were all these studies out there that said that that was going to give them better clinical outcomes because it would reduce the inflammation in the lung. So here comes this guy who did a study, and it was a very good, I mean, it was a well-funded study. It was funded by the National Heart, Lung, and Blood Institute, and it was sponsored by AstraZeneca, who I believe, I don't know, I'd have to look that up to see who, I think AstraZeneca are they the ones that make rosuvastatin? I think they might. Anyway, so what they did is they enrolled, it was from 2004 to 2009, so it was a very long study where they, they initially started off with their hypothesis was to prove. Their hypothesis was to prove that rosuvastatin therapy would improve clinical outcomes in critically ill patients with sepsis-associated ARDS. So here goes this group, and they were funded by AstraZeneca and by the National Heart, Lung, and Blood Institute, and they were setting out to prove that this was a good plan. And they enrolled all these patients, and to be eligible, they had to be mechanically ventilated, and they had to have evidence of ARDS, so bilateral infiltrates on chest x-ray. They had to have known or suspected infection, and some sort of criteria for a systemic inflammatory response. So a white count greater than 12,000 or less than 4,000, and then a body temperature more than 38 degrees or less than 36 degrees Celsius. And there's some more exclusion, whatever criteria, doesn't matter. So what they did is they took these patients and they randomly assigned them. So it was like a double-blind, randomly assigned. This was like a very pure experiment. And they put these people on a 40 milligram loading dose and then 20 milligrams daily of rosuvastatin, and monitored all of their, all of their data over a long period, over 60 days. And basically what happened is the first patient was enrolled in March of 2010, and by 2013, so they gave it a good 3 years, and 745 patients ended up being enrolled in the study. After 3 years, they quit the study because after 3 years of trying to gather enough data to support their hypothesis, they just could not. So what they've said here for outcomes is mortality and the number of ventilator-free days did not differ between the two groups. Statin use in patients with sepsis has been associated with reduced CRPs, and there was no difference between the control and test groups at baseline or during the study. And then they went on to say rosuvastatin therapy had no effect on mortality. So in this multi-center, which means it took place over several hospitals, double-blind, randomized, placebo-controlled clinical trial involving sepsis-associated ARDS, the administration of rosuvastatin did nothing to reduce mortality or to improve any outcome at all. And actually, through some of their studies, they found that it actually might have slightly harmed, because the only significance they could find was that the people who took the rosuvastatin had a small worsening of liver and renal function. So, good to know. I know that I work with patients on the ventilator in ARDS all the time, and I often see them all put on statins. As to whether or not they are put on statins for cardiac or whatever reason, I'm not sure, but I certainly will investigate that from now on as to whether that's just practice that everybody goes on a statin once they're on the ventilator, or if it's a cardiac reason. Um, it says here, observational studies have shown significantly reduced morbidity and mortality among patients with infection who were prescribed statins before hospitalization. In addition, several meta-analyses of these observational studies have suggested that mortality is reduced when statins are used. Our results challenge these observations and are consistent with a recent meta-analysis of 5 randomized controlled trials of statins in 650 patients with sepsis, which showed that neither atorvastatin nor simvastatin provided a benefit. Interesting. Very interesting. At least I find it interesting. And those are my 3.
Hi, Kelly. I found your case study very interesting about ARDS and how about the direct and indirect injury to the lung epithelial and the alveoli and how the inflammatory process and how how there's such a high mortality rate, even though it says it decreases, still at 40% mortality rate for patients that um, suffer from ARDS, and how that once if it is cleared up, that the fibrosis and the remodeling healing causes a lot of chronic illnesses if they don't come back from it. I found your first article interesting about the biomarkers of ARDS and how that they're trying to confirm a way to find these biomarkers to help diagnose and to identify the early chances for these patients so that they have a better fighting chance against ARDS, and also to help increase medical management for these people that are high risk for the development of ARDS. I also found your Article 2 about the epithelial dysfunction and how sepsis is epigenetic and how it decreases the expression of genes and it causes the microvascular leaks, and how lungs is a major one that always is caused in the genes, expression of genes. Your last article really struck me about how about the statins and how they were saying how it improves outcome for patients, and that actually the research found that after 3 years it does not make a difference whether you use a statin or not use a statin to help with these patients with ARDS, and that you stated that actually the research stated that there was actually a small worsening of the liver and renal function for some of these patients that were treated with this regimen and schedule of treatment with statins, the retrostatin. I got intrigued with with your last article about statins and if it didn't make a difference in medical treatment. So I decided to dig a little bit more research into this, and it said, and I found an article stated titled "Is it possible to prevent ARDS?" by JAMA and the Journal of American Medical Association, and it stated about how aspirin is they're finding that aspirin would be has been reported associated between out of hospital aspirin use and reduced risk for ARDS, and how aspirin could be a beneficial factor in preventing ARDS and helping with medical management of ARDS. So from that, I decided to dig a little deeper in about aspirin use and the management of it, and I found an article called "Effect of Aspirin on Development of ARDS in At-Risk Patients Presenting to the Emergency Department," the LIPSA randomized clinical trial. And it was an article also by the Journal of American Medical Association in 2016. It was a multi-center, double-blind, placebo-controlled, randomized clinical trial conducted at 16 hospitals, and they administered aspirin 325 milligram loading dose followed by 81 milligram or placebo within 24 hours of emergency department presentation and continued for hospital day 7. And they thought this could help prevent, this earlier intervention can help prevent development of ARDS. And they actually found from the conclusion that the use of aspirin compared with the placebo did not reduce the risk of ARDS at 7 days, and that they did not continue the trial because they did not find that aspirin actually did anything to help these patients in the long run. So it's just interesting to see that even with all this, these trials, that they're not finding anything that's still significant and establishing for prevention and treatment of ARDS, except medical management of the signs and symptoms that they present with, and that we need to, with future research and better understanding of the pathogenesis, we can hopefully find a better regimen and treatment for these patients, and ways to, like with the biomarkers, ways to identify early to help treat these patients and help decrease the mortality rate, especially with it still being at 40%. It really blew my mind with this information, and thanks for bringing it up in this voice thread.